Hello everybody, my name is Attila Bodrogi from Budapest. Today I'm gonna talk about some tissue preservation techniques which is quite favorable in my daily practice. Actually, I'm a comprehensive practitioner, I'm placing implants and I'm responsible for the prosthetic procedures on my implants as well. But first of all, I love challenges. I love challenges since the age of 6 when I started my sport career. I love challenges on the podium, and actually I challenge myself in the office, even during my operations. But guess what is the biggest challenge for me professionally? Well, it's bone loss. We all understand that this is a real challenge for the patients as well. Why? Because it requires multiple surgeries. Sometimes it comes with pain and discomfort and increase the cost and the healing period of time. Just look at this implant site. These two adjacent teeth needed to be removed a good couple of years ago, and this is the tissue loss. Just look at how compromised this site is. How can we place implants? First, we should start with the biologic concept of the extraction site. When we extract the tooth, we definitely face with the bone loss. And actually, the more time we waste after an extraction, the more tissue will be lost. From the literature and from our own experiences, we understood that the facial bone at the crest is missing sometimes, or most of the time less than 1 millimeter. So what if we extract a tooth? Well, what happens with the cortical plate? I would say it's all about the blood supplies. It's biology. So, regarding the blood supplies of the cortical plate, it comes from two directions. From inside, from periodontal ligaments, from outside, from the periosteum. So, when we extract the tooth, like in this image, we can clearly see that we don't only remove the tooth and root itself, but we remove the periodontal ligaments with the blood supply as well. So, in this situation, we lose the tooth, lose the periodontal ligaments, we don't have bone marrow, as it's purely cortical bone, especially in the anterior dentition, so the only blood supplies come from the periosteum. This is why it's so important not to raise a flap whenever it's possible. So if we lose the tooth, we will lose definitely the bone as well. So how can we decrease or avoid the bone loss? First option should be immediate implant placement. We know that we have to place far more palatal from the existing root axis my implants. Then we can leave 2, maybe 4 millimeters between the cortical shield and the implant surface. This is what we call kind of jumping distance. We need, in immediate cases, a very good implant system with a high primary stability. This is why I utilize most of the time this implant system from Megagen. It's called Enrich. It has a very nice primary stability and allows us to make one surgery one time. It means that I, whenever possible, place my implant immediately into the extraction sockets. So there's another concept which is a prosthetic one. It's called the dual zone therapy. It means whenever possible, place an implant, do some bone grafting and utilize an immediate temporary. We have to make a difference between immediate loading and immediate temporization. Now I'm speaking about immediate temporization. There's a multi-center study from 2014, and it shows us the less bone loss occurs when we make the implant placement, bone grafting, and temporary crown. but it causes less hard and soft tissue collapse and less recession. But we have to emphasize less. So, how can we avoid the tissue collapse at all? Any chance? We have to preserve the blood supplies. We could preserve it from the periostome side, but we have to make it possible from the periodontal ligaments. How can it be possible? This comes the option B, which is actually not a second choice. This is my first choice whenever I met the concept of, here's the solution, partial extraction therapy. Well, actually it's like an umbrella, and it gathers together 3 or maybe 4 different kind of procedures. The first one is socket shield, then Pontic shield, root submerge technique, and the modified socket shield, which is the Glocker. It's for delayed implant placement but leaving the shield. So it was, I think, 2015, so almost 5 years ago, when I made a roadshow in South Africa. It was actually an aesthetic and an implant roadshow. But one night we had a party together with my good friend, this amazing surgeon, Howard Luckman. And at one point of the night, he showed on his phone a couple of cases with socket shield. First I was shocked, but impressed with the end results. And on the next morning, when I came back to my office, I utilized my first socket shield. But how this concept goes on? The sketch shows us how the step-by-step procedures lead us to an immediate implant placement with shield protection of the cortical plate. So first we remove the coronal portion of the whole hopeless tooth. Then we dissect from mesial to distal, remove the palatal portion, shape the shield, place an implant to the crest level, and whenever possible we temporize it. Why? Because this is the concept of the dual zone therapy. So, as my good friend Chuck Schwimmer from the States announced, we should keep the good and lose only the bad portion of the tooth. So the sketch shows us those 3 elements, those 3 components, which is responsible for long-term tissue stability. And this is first of all the shield itself, then a good implant position, hopefully with a platform switching solution, and soft tissue which stabilizes the surrounding of this implant and the prosthetics. But we have to admit that implant dentistry is not just surgery. Actually, it's a prosthetic discipline with a surgical component. So why PET is my first choice? Because it's predictable, it's reproducible, and third, this is the least invasive procedure I ever met in implant dentistry. So the literature stated back to 2010 described this phenomena, first by Attila and his team, but the number of these articles are increasing day by day, and actually which is very interesting and proves us that this is a really, really good solution. Those histologic studies proves us that there's real bone formation between the shield and the implant surface, and this is very, very impressive. So there are different variations of the partial extraction therapy. The first one is the socket shield that I showed on this image. The second one is the Pontic shield, when we don't place implant, just leave the shield to maintain the cortical plate, and you can utilize a conventional Pontic site to your bridge work. Actually, there's a very interesting and very impressive team of researchers and clinicians, which is called the Dental XP PET Research Group. And I'm really honored to be part of this group. We share cases, we make some studies, we provide literatures. But let me show you first my first case when I returned back from my South African journey. And this was the hopeless canine. On the CBCT we checked there was strange apical formation and a very thin and fragile cortical plate. This image shows another case just to make you visualize how thin that cortical plate is. So now we understand if we lose the tooth, we definitely will lose the bone. Why? Because of the blood supply. So back to this case, I didn't remove the tooth, but dissected, removed the palatal portion. We have very nice kits, the newest kit, designed by Attila Bodrogi. We can shape the shields. Actually, this was my first case, and now you can check the implant position is not perfect, but the final outcome, checking on the CBCT after 6 months, shows the presence of the cortical plate and the shield. And actually, this is the clinical image. And from occlusal view, now we can see that we have 4 adjacent implants placed by myself previously. These are immediate implants, these are delayed, but the fourth one is the PET. And now you can definitely understand why PET is the winner, because it keeps the volume properly. Let me show you a new case from last year. It was an accident, and when I removed that broken coronal part of the right central, and I checked on the CBCT image, we realized multiple fracture line. And from a new study, we have a new classification of the bony profile of the implant site. And now we see that this case belongs to the class 2B. And to be honest, this is a really nice situation, because now you can imagine if I place an implant palatal from the existing alveolus, we have good primary stability with a good implant. So this is why I prepped, dissected, removed the palatal portion, shaped the shield. This is the ideal implant position, made my osteotomy, shaped the shield to the crest level. I utilized an energy implant in a palatal position. I always measure the ISQ of the newly placed implant, and this is how we ended up. And this is just 1 week of healing. No incision, no swelling, no bleeding. Very nice. Look at how the temporary shaped the soft tissue around my implant. This is the 6 months follow-up. Exactly identical tissue profile. So it's the concept of 1 surgery at 1 time. And this is the prosthetic solution, which is almost always 99% or even more percentage is screw retained in my cases. Look at this tissue profile, how amazing it is. The final outcome. And look at this collage, no incision, no suture, no bleeding, no swelling, no pain, no tissue loss at all. This is why I love it. So, socket shield is not only for anterior dentition. This case shows us fractured premolar, upper premolar. So I remove the palatal fragment, shape the shield, place an implant, make it immediate temporary, and look at how the tissue looks after 6 months with the temporary. No tissue collapse at all. This is the final crown, prosthetic solution, CBCT. The shield is clearly visible. The final prosthetic solution with the implant level deeply inside the bone, and we have existing bony peaks which supports the papillae. So, step-by-step procedure. In another case, hopeless tooth, we remove the content of the canal, dissect the tooth, remove the palatal portion, shape the shield back to the crest level, which is very important. We try not to damage the soft tissue, osteotomy in a palatal position, look at the implant position, and no bleeding at all. Measure the ISQ, made the bone filler material GBR, immediate chairside temporary. This is the profile, and 1 week follow-up. Look at this, how stable the tissue is. Look at that. And on the CBCT, the shield is clearly visible. Actually, this case is important and interesting because shows all three elements of the partial extraction therapy. So these are hopeless teeth. We need multiple implant placement, but actually look at how it looks after 6 weeks. It's just 6 weeks. So we have an old implant on the right side. We had root submerged, a pontic shield, a socket shield, and another socket shield at the side of the canine. No tissue loss at all. It's amazing. In just 6 weeks, one operation, one surgery, one time. The least invasive procedure in implant dentistry. So the indications, it's for immediate implant placement. Can be utilized if you have thin cortical plate, maybe the tooth is ankylosed, and it can be utilized both anterior and posterior dentition. And the contraindication is periodontally involved tooth, a vertical root fracture, loose shield after the extraction. But it's interesting, the periapical lesion can be okay with some kind of epicectomy. So some complications can occur with this procedure, and the most common two complications is the loose buccal shield when we try to extract only the palatal portion. In this situation, we have to remove the shield totally and place an implant like usual in an extraction socket, or we can go delayed approach. If we have some kind of shield exposure, we have to remove the crown. It's important to utilize fluiditaine solution, and we have to submerge deeper the shield, and the soft tissue will cover it. We can utilize it in lower dentition. It's a hopeless canine. Now you can see the prosthetic room between the implant surface and the prosthetic solution. It's 18 months, and look at the tissue profile and tissue thickness with no tissue loss at 18 months. Okay, the second variation is a pontic shield. Just look at this case. Is a very nice lady with this existing fixed bridges and crowns, but the problem we have with the right central, and of course we have some recessions at the canine, but let me focus on the right central. The lady refused having an implant, so it should be a pontic side. But just imagine what could happen if I removed totally this root with this very thin and fragile cortical plate. So I made my, let's say, socket shield. I started like usual. I removed the palatal portion, but actually it's a C-shaped shield. Why? Because I tried to provide support of my papillae on both sides with this C-shaped shield. And look at how it is. It's amazing. It's amazing. No any tissue loss buccally. We have very nice papillae on both sides. And this is the tissue profile. The pontic bridge, and this is the final situation. From frontal, now you can see it didn't lose any tissue, we just gained by adding connective tissue graft and the canines. And the third variation, and this is the last one, is called the root submerge technique. I know this patient from 1998, so it's almost 30 years ago, but I met him 2 years ago with this situation. Just look at this horrible tissue situation. We have multiple abscess, huge tissue loss, bone loss, and when I remove the hopeless canine on the right, even the threads of the adjacent implant is visible. So I utilized the GBR, it's sticky bone covered with the lamina and PRF. And this is how we started on the CBCT. And this is how we ended up after 6 months utilizing the GBR. So I would say now the site is ready for implant placement. And look at how much tissue we gained by utilizing the GBR. So my plan should be placing 3 implants, 2 on both sides to the GBR. But the third one should be an immediate implant placement. But as I didn't see any periapical lesion or problem with the second root, I decided to leave it, cut back to bone level, and let it covered by the soft tissue, and this is what we call root submerge technique. So here's the image of the operation. I checked the implant position on both sides, placed the implants, extracted the hopeless tooth. Now you can see how large defect we have on the buccal side of the implant. But I placed it far more lingual, made a GBR, and, which is the magic, I left the other root, I cut back to bone level, covered it with PRF, I took an immediate impression for the temporary, which is on the right side. I closed the site, and this is what we got after 3 months wearing that immediate temporary on these 3 implants. So this case is a combination of GBR, immediate implant placement with the temporary, and the root submerge. But from an occlusal view, now we can understand the difference on different situations, different procedures. So on both sides we have GBR with implant placement. We have an immediate implant placement in the middle, but actually the winner, keeping the tissue volume, is the root submerge. Just look at the small image on the right side. We left that root and let it covered by the soft tissue, and this is the safest and the most reliable procedure to keep the tissues. We utilize this final zirconia bridge on 3 implants. This is the tissue profile, and in comparison with the initial situation, now we can see how much tissue we gained, and this tissue is very stable because we placed the implants in a newly formed bone and utilized the root submerge technique as well. So as a final take-home message, I would say, and I would emphasize, it's much easier, at least for me, and much predictable to preserve bony and soft tissue structures than reconstruct. So thank you so much for your kind attention.